Thank you for joining me today to talk about intussusception and the role of sonography in the diagnosis of intussusception. So the first is, what is intussusception? Intussusception is really another, I will say, or one of the most common causes of emergent surgery in early childhood. Usually occurs between the age of 2 months and 2 to 3 years of age. It's referred to as telescoping of bowel or invagination of bowel. Means one segment of one loop of bowel invaginates into its own or into another one. So the proximal segment of that intestine is referred to as intussusceptum. The distal one, intussusception. So in other words, the recipient is referred to as intussusception. Usually there's a male predominance here. We're talking 4-to-1 male to female ratio. The most common location of intussusception is ileocolic. Then that can be followed by ileocolic, ileoileus, colocolic areas. So that's another thing. Also, something in there you have to also pay attention to as you talk about intussusception, whether that intussusception is a large bowel intussusception or small bowel intussusception. That's another thing to pay attention to. The reason I'm talking about that, because many of the small bowel intussusceptions tend to be incidental finding and usually seen in the mid abdominal area, and they tend to resolve spontaneously and within minutes, and the patient become symptom free. In other words, asymptomatic. Usually intussusception, the way we look at it, I don't say usually, but there is some recurrence for intussusception. So the tendency for intussusception to recur is 10 to 15% of the cases, especially in the first days after reduction. So that's something to pay attention to. So if I look at these pictures here, you can see how this loop of bowel is actually invaginating into itself. And then that's why it's very important. And now imagine when you actually do the ultrasound in this area of the loop of bowel, how this is gonna look on ultrasound. And I think that sometimes we always say there's a distinct feature of this on ultrasound. And I can tell you that, and I gotta say it way early before I show you ultrasound images, that once you see it, there's no way you can miss it on ultrasound. And here you can see that actually telescoping or invagination of those loops of bowel into each other as well. So I just want to make sure that you if you pay attention to this, you will be able to actually imagine and see how this gonna look on ultrasound. So surely now I'm not going to spend too much time talking about etiologies and so forth. Very often when we are talking about intussusception, we tend to talk about, well, what is the cause of it? What's causing this intussusception? So you'll hear healthcare professionals talk about some we may have there's lead points to cause it and or no lead points to cause it, or it's idiopathic. So reality here is this. So the most of the intussusceptions tend to be idiopathic, means no known etiology, no known cause, and there's no lead points. So, and if you take that and you think about the intussusception with lead points, they tend to be very uncommon. And usually represent around, I would say, less than 5% of the cases. So if you have let's say a 30-day-old patient or a child less than or greater than 5 years of age, intussusception with lead points are common. So you can see the distinction here. So again, yeah, it's common between the 2 months and 2 years of age, 3 years of age. And here we were saying, okay, well, children older than 5 years of age, the most commonly seen intussusceptions are really probably do have lead points. So that's what we are trying to say. So some of the lead points for that can be Meckel's diverticulum, lymphoma, duplication cysts, intestinal polyps, Henoch-Schönlein purpura, Peutz-Jeghers syndrome, or even somebody who had a patient who had surgery. So at this point, what we're talking about here with the Henoch-Schönlein purpura, If you are not very well aware of it, which I'm sure you know that you probably run into it in some of the requisitions that are given to us by referring physicians, that tend to what we call it this disorder that causes inflammation and bleeding in the small blood vessels in the skin, the joint, intestines, kidneys. If in our situation, if it's going to be the intestines here, so that's what it is. And one of the striking features, actually, of this disorder is there's this purplish rash that you see in the legs or the buttocks as well. So that we see these some of those requisitions come into play as well. And with the Peutz-Jeghers syndrome, where the lead point come in there because that's associated with polyps, with intestinal polyps, and that's why it is the relationship or the association with with intussusceptions. So, what are some of the clinical presentations of intussusception? What are the symptoms that the patient present with? Let's cut it short. The majority, we will call it the classical clinical triad. In other words, acute colicky pain, current jelly or bloody mucousy stool, and of course, palpable abdominal mass. I'm not going to spend some time talking about palpable abdominal mass because, again, depending on the patient's body habits, whether you're going to feel it or not. But again, this is one of the things. Of course, also we've seen vomiting, diarrhea as well associated with it. What's the importance of this? Because intussusception are highly important. Why? Because if we do not diagnose it, we do not treat it, that could lead to edema, could lead to ischemia, necrosis, could lead to perforation, to peritonitis, and that's what we want in there. So the way it happens, is when the mesentery is dragged. These things, because what happens in that situation, you get the mesentery. Maybe I'm here talking the mesentery gets dragged into or in between the loops of bowel. So the venous return is compromised, which leads to the edema, which leads to the restriction of the arterial blood supply, and that will lead to ischemia and necrosis. So this is like the stage of it. So really what happened here, the compromise of the vascular blood supply and drainage. And this is what you don't want to see in the loops of bowel due to this intussusception. So now we're talking about this. This is actually the talk about sonography. The question is, how do you perform the exam? What is the technique to do it? I know this could vary from place to place and all that stuff. I do believe in the people who do the ultrasound, the sonographers or whoever, the physicians, whoever who is doing this exam. But sometimes what happens if we follow a certain systemic approach in doing this exam or in performing this exam, can make it easier for us. So this way we don't miss any intussusception in the abdomen or the pelvis. So at this point here, very often, I really would like to put this up front here. Usually the transducer frequency is really truly determined by the patient's body habits. So the commonly say between 5 and 12 megahertz. Here we're talking linear array transducer. That's most commonly. But again, I do encourage you to think of the patient's body habitus and look in there and see if sometimes maybe the 12 is not working, the 10 is on. Maybe you can use 10 megahertz, 9 megahertz. You in some patients, you may want to use much higher frequency. So again, or lower frequency. So pay attention to the patient's body habitus. Most of those exams are really done in a supine position that will give you a better look at the area and also better, I call it posture, and as well, because you don't want to be stretching, you don't want to also be hurting your neck, your muscles, your arms, your shoulders. So that can be in there, and even that can be comfortable for the patient. It also, what's important for you and I is to really again get back to that systemic approach in there. Now, some people say, okay, well, we know the most common location is in the right lower quadrant, so I'm going to scan there first. Well, that's fine. But what if you start what we call it the mowing the lawn scanning technique? This is actually have been tested and have actually provided positive results. So again, I will not be able to make my lawn look like this, even if I mow my lawn. I mean, if I have my neighbors, they would be great. You can see their lawns are meticulous, unbelievable. I can't do that myself. So anyway, but with ultrasound, I will be able to do that. I will be able to go ahead, whether you start transversely or you start in the sagittal plane. You practically go in there and you go up one way, move a little bit, come down, um, and then the same situation back and forth. And that can be very helpful. This way, you will cover the whole abdominal and pelvic area and you will not miss anything. So you can do transverse, then you can do sagittal or vice versa, whatever is easy for you. And also the use of Doppler can be very helpful in terms of determining the vascularity. And that takes us back to the things that we talked about before in order to understand it, because if there is a compromise for the blood vasculature in there, the blood supply or the drainage, that will lead to ischemia, that will lead to practically necrosis, perforations, that will lead to actually peritonitis and mostly necrosis. So then the blood supply can be, because the blood supply can help us whether the loop of bowel is viable or not viable, ischemic or not ischemic. So these things that we have to pay attention to as we start scanning, but that's important. So what is the actually sonographic features? What are they? What are those features of intussusception? Earlier on, I just told you, if you see it, you will not miss it. If it's there, you should not miss it. The sensitivity of sonography in the detection of intussusception is nearly 100%. So that's why it's very important to that the thing that I told you earlier. If it's there, you will find it. So the sonographic features are really straightforward of intussusception here. Straightforward. Very often when you look at it, and I mean, what we always say, they have what we call it alternating concentric hypoechoic and echogenic layers. That's what it is. So really in what we call about there, the easy way to describe it is to say it has a hypoechoic rim with an echogenic center. So the hypoechoic rim is what we called it earlier, the intussusception, which is the receiving loop of bowel, where the echogenic center is the one that's going into it. That's the remember that. This is what I said earlier. That will become the intussusceptum, and that's what we have in there. So really, in many things you hear people or you read in the literature, it says it has a target sign appearance. It has a donut sign appearance. It has a pseudo kidney appearance. That's great. This is exactly what we always say, the typical characteristic feature or appearance of intussusception on ultrasound. The question that comes in there is, okay, what if there are lymph nodes actually that's dragged into that with that loop of bowel into it? What if there's the mesentery? What's going on? What if there's fluid entrapped within between loops of bowel? Surely that will change. That will change the appearance, this typical appearance, but it should not be missed. It's still gonna be close to what we talked about that earlier about the target sign, donut sign, or pseudo kidney sign. So once you know how lymph nodes look and then how they look when they are within their intussusception, then you should be in great shape. You should not be too concerned about it. On color Doppler, normal flow should be seen with viable bowel, as I said earlier. Poor flow or absence of flow can be associated with bowel ischemia, infarction, and necrosis. Also, what we have seen in there, the presence of lymph nodes and entrapped fluid, it has been described or been actually explained in the literature that they do tend to decrease the likelihood of non-surgical reduction of intussusception. Is it always the case? It's not always the case, but that has been actually discussed and presented in the literature. Here's your classical appearance. I'm not gonna, you see it, it's right in front of you. I'm sure many of you have seen it. Many of you have experienced it. This is what it is. The most typical appearance of intussusception. This hypoechoic rim and this echogenic center. This is your donut. This is your practically pseudo kidney. This is, of course, in a transverse plane. And also the target sign. Practically what happened, the hypoechoic rim is your intussusception. This is the receiving loop of bowel, and this is the intussusceptum. That's the one that's invaginating in and going into the loop of bowel. So you can see, no matter what I show you, different ones, I mean, they're gonna look almost the same. This is the one, it has the typical appearance of that. So you should not miss it. This should be 100% diagnosis. That's the way it looks on ultrasound as you see those type of pediatric patients. Here, the same situation. You got a 5 years, a 1 month old boy with abdominal pain. You look in there, you do the ultrasound. This is exactly what you got. You got this beautiful center, again, echogenic center on the hypoechoic rim. Then you can go sagittally in there. I mean, you sagittal, it's not going to look like this, but again, it's closer to a C. And you can see that actually there's a lymph node sitting there. But again, this is important to actually scan it in both transverse and sagittal plane. It's all good to have that habit. So show it in at least two different planes, and that becomes convincing. So here we go. If I go ahead and say, now I see the intussusception in grayscale, I see it, it's in front of my eyes, great. Now the next one that comes to my mind is, okay, is this really viable? Is not viable? Is there blood flow to it or not blood flow to it? I need to know that. So when you do that, you do the ultrasound, you practically turn on your color Doppler, and then here you go. You see this beautiful Christmas tree lighting in front of you. So immediately then you say to yourself, well, okay, I got intussusception, I see the flow, hopefully this is viable. So now when you say all of that, when you actually present it and talk about it, the referring physician say, okay, now probably what we can do, maybe we can go ahead and reduce it and do whatever we need to do to actually treat it and move on. But you did your job. You made the diagnosis and you gave them information that can be very helpful in the management and the treatment of that patient. Now, this is the typical, right? This is what I mentioned to you earlier. This is your typical appearance. This is your beautiful thing. The question is, what happens there in this situation? Now you look in there, you can see the intussusception, right? There's there, but now this addition of this little tiny hypoechoic overlooking areas in there. So what is this? Immediately in yourself, remember what I said. Sometimes what happens as this intussusception invaginate, or as intussusception occurs, with this loop of bowel starts to pull invaginates into another or into itself, sometimes it pulls with it some of the mesenteric or the mesentery and also lymph nodes. In this situation, what you see is there are some lymph nodes being actually entrapped in there, being actually pulled into this intussusception, and it changes some of that, what we talk about, that appearance, typical appearance. But again, it's still intussusception, sits in there, it doesn't go anywhere. And then once you go ahead and turn on it 90 degrees to this transverse plane, you go sagittally, and this is exactly what you see. You see this whole intussusception there. You see the lymph nodes in there, and also but the blood supply still there. There's this color Doppler, and there's brightly showing that there's still flow going into this intussusception, or maybe perhaps it's going out. But again, this is important for us to understand and to keep in mind. So again, these things, as I always say, pay attention. There are sometimes you have the typical appearance, but what happens, if something added to that typical appearance, surely is going to change that appearance slightly. Having said that, now I'm going to show you something else in there, like what happens if fluid gets entrapped between loops of bowel. Well, in this situation, it still looks like intussusception. You can see that there's a loop bowel inside, and there's some fluid that's entrapped between the loops of bowel. So at this point, you say to yourself, now I got this intussusception, there's some fluid entrapped in there, and that's okay. Again, that determines also the management and the treatment. That can be very helpful to actually provide that information as we move forward. So again, you can see another intussusception there. You stretch it out, you see that the loop of bowel inside. But I could show you many cases of this, and you say to yourself, okay, well, they all look the same. Well, yeah, I told you, it's typical appearance. But make sure you pay attention to that. Pay attention to those. I keep saying it. I have said it 10 times. I'm stressing it. That sometimes it may slightly change, but will be the same. Here, again, what you see in there, this is intussusception there. You can see that, again, the same typical appearance. You rotate on it, you stretch it out. You can see this loop of bowel there. And then you can see how this guy going in almost coronal sagittal plane is going into the other ones. You can see, actually, it is practically invaginating into the loop of bowel. So that's great look of intussusception to show that regardless wherever it is, it could be in the right lower quadrant, ileocolic, fine, that's great, or ileocolic, or it doesn't matter. At this point, you have made the diagnosis, and everybody will be happy, will be moving forward, because we have the diagnosis of why this patient is having the pain, whether intermittent or not. But now we did a great job in diagnosing intussusception with ultrasound. Having said that, I want to thank you so much for your kind attention. You always remember that sonography rocks, and I'm proud to be one of you. Thank you so much. Take care of yourself, and we'll see you later in another episode of perhaps pediatric ultrasound emergency.